Good. All right. Hello, everybody. Good morning. We'll call the meeting to order. Our first order of business is roll call. Shelley, I know we pseudo went through it, but I do think we have to go through it again.
How about if I read the names I didn't?
Perfect. I like that approach.
Let's see. Candace Williams. Jackson. Terry Lewis. Cody Usher. Laura Smith. Michelle Guadagnola. Paul Dabrowski. Ralph Kelly, or Zane Kelly, sorry. Shanna Clough.
I'm here.
Sean Bowker. Tiffany Strieber. Count 15. We have quorum.
Okay, thank you very much, Shelley. First up,
Hi, Shelley.
Chairman's report.
Sorry. Who's speaking on the online?
Sorry, Shelley. It's Laura Smith. I just joined.
Oh, hi, Laura. Thank you.
Thank you.
Excellent. I want each of you just to take a moment to look at the attendance report. Just a friendly reminder to everyone, we encourage your participation in this meeting. Thank you for being here today. If you do miss more than 2 meetings in a row, the Bureau will reach out to you to ask if you're interested in continuing in your role with this committee. Next up, I'd like to welcome a new committee member, Danny McNeil. I think I heard him on there somewhere.
Yes, I'm on.
Welcome, Danny. Thank you for your participation in this committee, and we look forward to your expertise.
Thank you for having me and the opportunity.
Awesome. We do have one vacancy. If anyone is interested in filling the spot or knows someone qualified to fill the spot for ground ambulance or first responder premier EMS agency quality improvement officer, please nominate yourself or someone else for that position. You can send that nomination to Sarah Parati, the executive director of the Southern Arizona EMS Council. Last thing on my list is the meeting schedule. I believe, actually maybe not, there is a link on your agenda and it is up on the monitor. And for those of you online in front of you, please take a minute to glance at that schedule and make sure these meetings are on your calendar. The next meeting, as you can see for us, falls in November 20th. Look forward to seeing you all then. With that, I will turn it over to the Bureau staff for the Bureau report.
Hi. Hi, everyone. I'm Nicole Witt, Assistant Director of Preparedness. We did something a little bit different this time around. So there is an attachment that includes our Bureau update. So we thought maybe this would be an easier way to communicate going forward. We are continuing still on the hunt and the search for a Bureau Chief. So just like members of this committee, if you know anyone that's qualified and interested, it is still open and we have ongoing recruitment until we find the right candidate. So definitely encourage you to continue to share that opportunity as widely as you can. I was going to go through this, but I won't do it justice. So I was going to turn it over to Julia to give the service section updates. And I'm sure Dr. Bradley might have a few points to know as well.
Thank you, Nicole. So just a couple of updates from the services section. We're still working on developing our operational plans for each strategic plan priority for this current fiscal year, which just started at the beginning of this month. For the EMS for Children program, we have recognized 6 agencies as part of the new MARC program, which is really exciting. That's an EMSC performance metric that we're really excited to have met this year. And we still have the neonatal resuscitation program training available for naloxone leave behinds. We're up to over 60 agencies participating and still promoting that and accepting agencies on board. For the shared program, we can skip that for now and discuss that later in the agenda. And I just wanted to make a quick congratulations for this year's EMS and Trauma Awards winners. That was announced at this past EMS Council and staff meeting, but those winners are on the website if you would like to review those. And then Lastly, I will just say, for data quality assurance, the trauma registry is not quite ready yet for Q1 data submission. So Chris will be reaching out to the appropriate stakeholders, when that is complete. And I think that is it.
All right, anything else from the Bureau? Excellent. Turn it over to our subgroups for some updates. First up is our trauma registry user group. Maria, updates.
Good morning. From the registry standpoint, there's not much. I mean, we're still so new to the ESO registry. We had an in-person training at Honor Health Osborne, and it went very well. A lot of information. I mean, that's mainly it. I mean, there's a lot of learning still. Like, there's a lot of report classes live, but there's not much. I mean, we're still so new to the ESO. That's all from the registry point.
Thank you so much. Next up, trauma manager workshop. Heather.
Hi, yes, we had our last trauma program manager meeting on June 27th in Flagstaff. It was a great meeting. There was a lot of bureau updates, similar to the registry. The registry has been a lot of changes and updates and trying to get things organized for good data collection. Chris has been key in that, so we really appreciate her. They talked about some maternal transport and OB trauma cases. And our next trauma program managers meeting is going to be in October in Summit and Show Low.
Excellent. It's a great time of year to be in Show Low. That'll be fun. Next up, EMS registry user group. Right.
Yeah, thank you, Dr. Gaither. So the EMS registry group met on the 6/18 and 25, 10 o'clock. There was actually quite a bit. There's quite a bit of people there also. One of the things that Ann was covering was make sure agencies are getting their weekly and monthly reports by email. If you they're now sending multiple small reports. I know everybody's getting a lot of reports. They're now coming as one big report. If you don't want them, please feel free to subscribe. You don't have to receive them. If you have any feedback for Ann, she's more than willing to look at them if they want to be changed or any kind of stuff that you would like to see on there. Also, there on June 12th, the shared cardiac arrest data quality report will be coming out, and it should be on the 12th of each month after that. Make sure if your agency, if it's applicable, you're applying the updated schematrons to prevent any kind of reporting issues. I guess there's some issues with some departments with outdated schematrons having some reports and validation issues there. So if needed, and can also meet with your agency and or the vendors. The other big one change coming was there's a change log order for NEMSIS 3.5.0 upcoming. It's outside the norm. And the reason why is there's some of the, due to the executive orders that are going on, I believe it's patient 13 is the actual NEMSIS data point. It's caused some issues. And in September, they should start accepting pending the critical update release if it comes out on time. The other big change log is 3. I know we're at 3.5, 3.51 change log highlights. Their ADHS is hoping to start accepting those in 2026 sometime. There is no main time for that yet, but that doesn't matter because none of the vendors are compliant, so nobody freak out at this time. And there's actually quite a bit of changes on those from airway, arrest, e-history, patient. There's about 12 of them. So those will be here, more information as those come down soon.
Great. Thank you, Ryan. All right, moving right along, we're on our way to discussion and action items. The first item is to discuss, amend, and approve the draft minutes from our last meeting. The members have those in front of you or in your packets. Those online, please take a minute to scroll through them. And if anyone is interested, I will certainly entertain a motion to approve or amend as needed. Thank you, Dr. Dabrowski. I have a motion to approve. Is there a second?
Heather Miller, second.
Heather, thank you. Any discussion about the minutes or any requests for modifications? give it just a second and then we'll call for a vote. All right, hearing no discussion, all those in favor of approving the minutes as presented, please say aye.
Aye. Aye.
Aye.
Thank you. Any opposed, say nay. Any who wish to abstain, say aye. Hearing no nays or abstentions, we'll consider the minutes approved as provided. Next up, we're going to discuss the share registry program and some updates. I don't know who's going to do this one, Dr. Brett?
We will do a little bit of a combination. I think we'll start with Adam.
Hi, everybody. This is Adam. I hope you can hear me. So we wanted to take a minute and update you on some share transitions. I can share the slides, that short slide set, if that's okay now.
All right.
Sure. We are moving from CEDAR to REDCap, and if you don't know what those are, I'll explain that. So in order to follow an out-of-hospital cardiac arrest into the hospital, we collect two data sets. One data set comes from EMS, AZ peers through their normal charting processes, and the other data set comes from the hospitals through a system called CEDAR. And the abstractors have been using CEDAR since it originally came out in the mid-2000s. Since the program has transitioned to ADHS, we're attempting to modernize this data collection process. And so CEDAR was our old data collection engine, and now we are moving to REDCap, which is promising to be far more friendly and far more cost-effective than CEDAR. So for my hospital data abstractors, they will enjoy a couple of features about the data entry into REDCap. And so what you can see here is just sort of how the systems are going to behave when compared to each other. The first most noticeable difference is a major reduction in the number of questions. CEDAR asks 68 questions, almost 100 if you include all the targeted temperature management questions. REDCap asks 34 possible questions. And that's due to skip logic you see below there. In the old form, the abstractor would have to choose, is this a STEMI case? Is this a out-of-hospital cardiac arrest case, or what have you? In the new form, you are simply going to be piped to the correct questions that apply. So you're going to go to REDCap and only see the questions that apply to the case you have, as well as the type of hospital you are. We did get some feedback from our referral facility partners that they frequently didn't have enough information to answer all of the questions because the patient moved on from their facility to a higher level of care. So that skip logic is going to be really nice in terms of, not having to deduce what's what. It'll just be, you'll only see what's applicable to you. And so some of the questions that come along with this are, not some of them, the questions that do come along with the CEDAR conversion are the same questions that they are asking at the national level through the system called CARES, which is the national level of our shares. So that's the cardiac arrest registry for survival. And so these are the questions they ask. And instead of subscribing to CARES proper and incurring those fees and the implications that come with subscription to CARES, well, we thought it would be okay to just ask the questions ourselves in our own system, and then we can be comparable on the national scale. So see, these are some of the questions that, if you're familiar with the data set that we captured previously, you'll see that there's a bunch of elements that have been that aren't here. A lot of our information we were having you enter was floating numbers like blood pressures and temperatures and things like this. So we've gone ahead and done away with that. Some of these questions are similar to previous questions. Some of these questions are the pick lists from previous questions. So some of the questions and answers sort of got turned inside out from this transition. But these are some of the questions the abstractors can, I don't want to say be looking forward to, but I keep saying that because I think it'll be a wonderful change to have our data abstractors entering far less information. And this gives us several advantages. I think it's, first of all, again, it's a reduction in the burden of effort for abstractors, and so that leads to faster turnaround times for the information. Asking the same questions allows us to standardize with the nation and benchmark against the nation, have a look at ourselves and what we're doing, and hopefully ultimately improve outcomes from out of hospital cardiac arrest and STEMI. That's what I had for this short presentation. I'll pause for any questions or if anybody else has anything.
Thank you, Adam. I'll kind of add on this. There is a big push at the national level over the last few years. There was substantial funding approved to support CARES, with really the goal to get all of the states to participate in CARES across the nation. One of the challenges that we've had is just some funding that is associated, and also kind of how we get that data entry accomplished, because there's two entry points, both at the CARES, the national data set, as well as with our AZ CARES and CEDAR system, which will now be REDCap. And so recognizing that to ask hospitals to do a big transition to a national data set may be a little bit challenging, especially as everyone is facing some budget cuts. So we do feel that this aligns our data elements. That was one of the big goals of the team, was to say, let's make sure our data elements are the same across the national system. In talking to CARES leadership, they are doing a lot of the work that we've been working on over the last 2 years, which is modernizing their data entry system as well. So they've had the same challenges. CARES and SHARE developed at the same time, really, and kind of have evolved. But both programs really needed a big data upgrade, and that is part of the process. So this does align our data, allows us to say that this data matches. So if anyone wants to compare moving forward, how does Arizona's data compare to a national standard? We're now looking at the same data set, which is really helpful. So I think that will be a great move in the future. The other thing that we did want to continue that's a little bit different from CARES is that we have historically collected STEMI data. And that is something that we would like to continue to do, because we recognize that this is a patient population where that pre-hospital intervention and recognition has a substantial outcome difference for the patient. So recognition of that STEMI pre-hospital, activation of the cath lab, et cetera, really improves outcomes and saves lives, which is the mission of the SHARE program. So we do want to continue to collect that STEMI data, and hopefully with this reduced data set, the burden for our abstractors at the hospital level will be much lower. So a big thank you. Adam is not demonstrating all the work that has gone behind this, but with him and Joe Stotzel, and to kind of get this to where we are. So a big thank you to the team for doing this.
Thanks, Dr. Bradley.
I have several questions, if you don't mind.
Yes.
Sorry, all. When is this plan to go into effect? What's your kind of change date? Do you have one?
I might be able to answer that in loose terms, Dr. Gaither. We would fully expect this platform to be up and collecting data by the end of the year. I can confidently say we would fully expect that. We would like to have it up and collecting data within the next 90 days is our goal. So we want to get this switched over earlier than later to save those abstractors some effort. One thing we're trying to hash out is the logistics of launch. Is it CEDAR's closed one day and REDCap opens the next, or do we open it up? Do we have two platforms open? So that really I have to bounce off our team, and that's sort of some of the reasons why I can't pin down an exact date.
Totally fine. I was looking for a ballpark anyways. If you had given me a date, I would have been very surprised.
That'd have been weird. Yeah.
Would be good.
The other follow-up questions are kind of all along the same thing, but as you know very well, Adam, the people that enter this data are not our traditional EMS people. They may not necessarily work with the Bureau of EMS and Trauma, for sure they don't. So my question is there going to be training available for people to use to learn how to do this? How are we going to notify them that the change is being made? Because many of them, quite frankly, may do this once a month at the most. And then how are we going to get in touch with all these individuals? Is there like a training and dissemination plan somewhere in the works?
Absolutely, there is. Yeah, that has been the focus of much of my effort is the document infrastructure to support this. And so two of the major efforts are going to be the data dictionary and the data entry guide. And those are two different documents. The data dictionary is a little more technical, and that's reserved for validation processes. and things like that. The data entry guide, I think, is the more meat and potatoes about this is the website, this is how you find an account, this is how you log in, this is how you enter cases. So there will be a great deal of literature to accompany the communication with my share you. I don't know what to call it yet. So I'll just say share user group for the moment. But I do have I am in communication with my user group, and they're very responsive, and I think they're all very much waiting for this change to occur as well. So yeah, I do communicate this out with the user group, and so I hope there's enough. I hope I provide enough that it should be a one-stop. You can take a look at these couple of documents we produced and have a full understanding of what needs to be done.
Perfect.
And I think just to answer kind of the other part of your question, so behind the scenes, Adam and the team really works directly with all the cardiac receiving and referral centers. So he has contacts for each of those centers. Some hospital systems do it at a system level, but we do have contacts with all of them. That was one of the processes we went through just about 3 years ago with Julie and I went through kind of going through a renewal process for the cardiac receiving and referral centers to ensure that we had kind of a contact person at each facility. Historically, the facilities kind of applied and they had that status unless they notified us of a change. And we really felt that a 3-year renewal cycle allows us to make sure we have a good point of contact, but also make sure people still qualified for the level that we're recognized at. So that was one of the things that we put into place, is that 3-year renewal recognition cycle. The other big accomplishment that the team has done in the last month or so is they've actually been able to missing cases for 2024. So that was something that previously was done very manually by U of A. And that is something now, though, some of the technology advances and what the team's been working on is they've actually had that missing list and been able to send that to the facilities. So I do think there's good communication, even though those individuals entering the hospital data may not be EMS related, they're pretty well engaged with the team here.
I don't know how many cases were missing. Like, was it a huge percentage or was it a small percentage?
I know we did ask that question. I know that Voxel, I think, was running numbers. I see her on the line. I don't want to put her on the spot. I think we can find it, but we got I think a pretty good percent of those. That's what we were trying to look to see, how many of the missing cases did we end up getting. But we had several facilities that one of the pieces that we're doing now in a more regular fashion is tracking data entry. So if we see a facility typically gets 15 cardiac arrests a month, and all of a sudden we have a 6-month period with 0 cardiac arrests, that's kind of a sign that, hey, are we not getting the data entry? Because if you have a persistent number, that should be relatively stable. So that's what we're doing as well with this renewal cycle, is trying to stay on top of that. The data entry for the hospitals that this group had recommended was to stay on the trauma registry data entry cycle. So really to kind of keep it a little bit more up to date. So it's quarterly data update for the
I imagine there's probably some places that have much higher percentage of missing cases.
So what we would like to see is to take action. So our protocol, just as if we were at any other venue.
I think you came with mute. You have something for the group, or was that accidental? I'm going to guess accidental.
Some EMS agencies' data may be impacted more greatly by a specific facility than maybe other facilities. So it might be good to have that number of missing cases, just because if one agency has half their cases missing, their data might look much different.
Yeah, I agree with everything that's been said. The asterisk next to the missing cases is that we query AZ peers for any of the e-arrest fields or the same fields that we look at for the PEAP program, the Premier EMS Agency program. And so it isn't infrequent that they don't have enough information to enter the cases, or it might be a wrongfully checked box that might have put them in that population of an out-of-hospital cardiac arrest. And so we're not ever certain what the exact number is. So there will be a little bit of variance around the missing cases, just due to the fact that we are getting it from AZ peers, and there may be several reasons why an abstractor wouldn't enter that case or couldn't enter that case.
I only have one more question. It's a little bit of a leading question. As you all know, there's 2 ways to use REDCap. I'm assuming this is going to be a link that our data entry specialist can click on and enter cases. There's no need for a login or anything like that with this new red cap system. Is that right?
Actually, this will be login driven. That's I don't know why it occurs that way. It just is. Well, I may be speaking too soon. I want to say that our individual users will have logins, but I think I'll actually rely on the data team to double me up on that. But Dr. Gaither, I think that each individual user will have a login, and it will be accessible such that one abstractor can abstract for several hospitals and the opposite as well. So we'll have to figure out how to put each of the data access groups into buckets. So one person might be abstracting for several sites, as well as some sites might have individual abstractors for the individual site. I see Josie's got her hand up. Thank you, Josie.
Yeah, no problem. I can answer that. They will have logins, and one of the biggest reasons for that is so that they can see the cases that they've previously put in, and they can have in progress status. Because if we sent out a link everywhere, that would not be possible. So they will have logins, but that'll be taken care of with very clear communication on our side. So hopefully the process of getting everybody into the system won't be too difficult.
Thank you, Josie. And then I'll follow up with my plea. Please make that help button to reset your login very, very obvious. We are poor system users when it comes to logins. So anything you all can do to help us with transitioning roles and people coming in and out of roles and having trouble with logons would be hugely appreciated.
Absolutely. That's the goal.
And, we wanted to say a big thank you to everyone. I know people have been asking, where is the share report? Because we have not had one for a couple of years. And really part of this is making this big transition. It's pretty substantial, not only from transitioning from outside the department into the department with all the data sets, but then also coming up with a new way to link the data that is automated versus manual. That was one of the pieces that really needed to happen regardless, just from a FTE perspective, and then really modernizing the data, ensuring that we aren't asking questions about hypothermia, which hasn't been recommended for many, many years. So some of the data fields were really dated. And so one of the pieces we do know is once we go live with the new data set, there will be some differences in our data. And so we're really going to want to communicate very clearly. This is post-change new data elements. What we're looking for, this is kind of the previous data elements. We do recognize that there is a gap and thank everyone for kind of your patience with this. But I think overall, we are really moving in a great direction and aligning kind of with some national standards.
Thank you. Any other comments or questions about the share before I move to the next agenda item? Right.
Quick question on the data entry for fire EMS agencies. Is it going to be manual or is it going to be automatic from AZ peers?
From AZ peers.
And so for those agencies that don't report and strictly do like just a response only, would they be able to enter it manually? That's how I know how shares or cares as a whole, you can do it either. If you're a big enough agency, you can do it automatically, but most of the time it's done manual.
I'll let Ann answer the question just because she knows our AZ peers agencies, but we have lots of tiny agencies that with the image trend system and the state database that most everyone I think at this point is submitting data. So Ann, I don't know if you wanted to touch on that.
Yes. Hi, everyone. So Gail's correct. Most of the agencies in the state do report to AZ peers. There's some exceptions, but and if you have anybody specifically, we can discuss, I guess, offline. I don't know. I don't want to shame anybody if they're not, but there's not a way to report this data unless you submit this data to AZ peers. And part of it is these are going to be cardiac arrest data points. So unlike with the opiate overdose, where we kind of have a separate process for those that are not reporting a full EPCR, even though there are just specific cardiac arrest data points, share registry is still going to rely on some other additional data points that aren't just the e-arrest ones to be able to do some kind of linkage and matching up and, date matching and things like that. So yeah, there's not a process at this time. And I don't see how we could do that, but I'm open to ideas if the share registry team has any.
Okay, thank you.
Anyone else? All right, we're going to go ahead and move on to the next agenda item. Oh, I'm sorry. I skipped the second part. Premier EMS agency out of hospital. We kind of touched on this, but if there's more sample reports, I'm sorry, in findings summary.
For that.
Okay.
That's okay. Yeah, I have a short presentation I'm going to give for those of you that were at EMS Council. This is going to look familiar. For those of you that have already been getting the report, hopefully also the information is something you're already familiar with. Let me see if I can. I know Shelley has access to this, but if not, let me. I'm going to try doing it on my own, and then if I need to do something. Okay. So. And then, there we go. So hopefully, oh no, it's not doing it on the same screen. Okay, are you guys, you're not able to see, or are you able to see it?
We can see it.
Okay, all right, let me.
Oh, now
It's
we
okay.
see lots.
Yeah, I know. It's because I can't manipulate it. I know. We see lots of us. That's okay. All right. Why isn't it not doing this? Okay.
Now,
Every once in a while I have this problem. Shelley, do you want to just present it and then I'll.
Sure.
I don't want to waste everyone's time. Every once in a while I have this issue, so. Okay, thank you. All right, so I'm just going to do a quick presentation about the out-of-hospital cardiac arrest data quality share report for the Premier EMS agencies. So if you are not a Premier EMS agency, you currently are not receiving this report. But if you would like to be a Premier EMS agency, which I highly encourage, please, you can contact me and I'll send you on to David Harden, or you can contact David Harden. And so the purpose of this whole initiative was to improve the data quality related to pre-hospital auto cardiac arrest documentation, because as a great segue we just had, it is used by the share registry, and it's really, really important data and very, very impactful. The population of this report, so kind of what's going to be included, is unlike other data quality reports your agency may be receiving. It only includes out-of-hospital cardiac arrest patient EPCRs. So it's focused on those. And as Adam rightly put, if someone checks a box though, and it looks like it's an out-of-hospital cardiac arrest and it's not, then it's going to be included. But that's something that this data quality report can help us address, because if you see something strange in your report, it's a great way to contact me and we can determine if maybe there was an issue with something being checked, or perhaps there's something that we need to modify in our report. That's always a possibility. Timeline, the newish Premier EMS Agency Share Data Quality Standard was effective as of January 1st, 2025. In April, we sent out the entire first quarter as one block to everybody in the report I'm going to show you. And then every month since then, you should be receiving, I believe it's right now scheduled to go out on the 12th of each month, an individual monthly data quality report that reflects just the last full month of share data. And then the measurement, just to keep everything consistent, because it just makes it easier for all of us to remember, is the target is a median validation score of greater or equal to 90, which is the same as what your overall validation score should be for Premier EMS agencies for your data quality anyway. And the evaluation is still the same quarterly. So even though you're going to get the report every month, it's going to be something that is going to be evaluated as far as your status in the Premier EMS agency program on a quarterly basis. And of course, though, what we want to do, our ultimate goal is to work with the agencies to improve data quality, not to necessarily, remove people from the Premier EMS agency program. So when you get these reports, and I know sometimes people, someone leaves a job and someone else comes in and nobody realizes that somebody's not getting the report. The whole point is to get the data quality up. So it's not meant as a penalty thing, it's more meant as something to assist our new registry. Okay, next slide, please. So really quick, I won't go over each one of these, but the data quality report targets these specific data elements. These are the ones that are highlighted in the report. So they're all cardiac arrest ones. Next slide, please. Okay, so what agencies should be doing when they get this report? Review the number of out-of-hospital cardiac arrests that are listed. So it's the number that we said you had last month. If this does not match what you think, either too many or too few, that's something to contact us about. The overall data quality metrics, there is a median validation score and a range and an average to kind of show you where you're falling. In the example I'm going to give you, the median meets the standard, but you can notice the average is a little lower. It wouldn't affect your PEEP status, but it's something to know that there's at least a few that probably could be improved upon, and we can hit those. And then specific validation issues to determine where an improvement can be made. So the report has those 3 sections where basically it's a summary of your data quality and the total. It lists most affected e-arrest data quality to least in like a table. And then it gives you each and every issue with the incident number so that you can use those as examples to go check your own database. And then we can work together and determine what's going on. Next slide, please. Okay, so this is an example of the report. And at the very end, I'll just show you that it's all on one page. But so the first segment of that report, that's what it looks like. You have, this is our premier EMS agency department. So you just stick in whatever agency name you are. And then this happens to be an example from a February data. So the share data quality of 92, it would meet it, but there's an 87 for average. So maybe there's still some things we can improve, because the lower the score, the less data that we're getting to share that they need to be able to use. And then it gives you a range to kind of give you an idea of where you're at. And in this case, the total number of cardiac arrests that we calculated for that month are 12. Next slide, please. Okay, this was the second part of the report where I talked about how each e-arrest element is targeted so that the validation just for those are specified here, and it's listed if there are any issues, because sometimes there's not, and this will say if this is blank, then you don't have anything that came up. Then it's listed in most often triggered to least. So in this case, 8 times that top rule was triggered on the 12 EPCRs. So sometimes if it's something that goes off multiple times, you could actually have a number that's higher than the number of cardiac arrest EPCRs, but generally it's going to fall within that. Most of the rules just are, single documentation requirements. Next slide, please. And this is the last part of the report where, and this is just like a snapshot of it. It wasn't the whole thing, but the one that we just saw was a list in order of validation issues for specific cardiac arrest elements. This one lists out for each incident number. So it's grouped by incident numbers. You can see at the top under the PEEP EMS department name, there's an incident number, and then it lists what issue needs to be addressed with that EPCR. And it keeps going down. And the last one, you can see there were 2 issues that occurred with the 1, 2, 3, 4, 5, 9, 5 EPCR. And so it allows you to go into your system. A lot of times what we find is you go in your system and you're saying, hey, no, it's documented, or I've got something there. And that's when we can work together with your vendor. And sometimes it's not being sent in your XML file. Sometimes it is, but it's being mapped to a not value, which we found too. So what we get is what this is based on. So we're not getting it, or we're not getting it in the right field. It doesn't mean you're not doing it though. So usually we can solve this. The vendors are usually really helpful and eager to meet so that we can work on this. And next slide, please. And that is it. I just wanted to show really quick. Could you give me back control? I'll just show, it's taking like 2 minutes so I can show you where this stuff is. All right. There's my lovely multiple screen. Okay, so first of all, let me show you this report. And we're hoping that, I know this is small, but you already saw this exact report on the screen. I just want to show you, this is what it looks like. So it tells you when it was generated. In this case, that's when it was generated. It gives you all of the information about if there's 0 given, then that means you'll still get a report. But that means we have 0 cardiac arrest for you for that month. That's still important to know because maybe that's not the case. The reason your validation score is going to be more impacted sometimes when you look at this cardiac arrest report is it's a much lower number of EPCRs that are being evaluated versus your larger data quality ones. So any issues are going to kind of stand out more, even with the median. If you only have 10, and the median of that happens to be not as good as your overall. So this is why we target just those. And also the overall data quality on the top, that actually is impacted by things, any data quality issue, because it's the whole EPCR's data quality as a whole. And then the only other thing I wanted to show you, and I won't read through this, for those of you, and I think there's a lot of agencies that really want to know exactly, you can't solve something if you don't know how something's built. So there's a supplemental document, and it goes through exactly how this report was built, exactly what the inclusion criteria are, what the codes that we were looking for were used, and the data elements that we're looking for in that report. And the reason this is helpful is if you want to try to replicate this in your own system, you can do so. And like I said, we don't match, that's a place for us to start. And then the only other thing is where to find this. So hopefully everybody has bookmarked the AZ Peers ADHS page, data quality assurance. And when you go in there, you go under education and tutorials, it's linked right here. And if you don't find it and you want me to send it to you, I'm happy to do so also, but this is where you could find that supplemental guide that has all of the detailed information. And that is it for me. Thank you.
Excellent. Thank you so much. Questions for Anne? All right. You get applause and all. Love it. All right. Now I'll move to the next agenda item then, which is to discuss the heat dashboards.
Thank you. So I will cover this briefly. I just wanted to share that we do have the ADHS heat dashboard, and we linked it to the agenda because it's a little bit tricky to find if you go actually just Google searching it. But there is quite a bit of heat data available out there, both at a statewide level. You can filter this to the county level. This is just to clarify, not EMS data, and we'll get into that in the next discussion item. This is really specific to emergency department visits, although the presumption is that likely the majority of patients coming to the emergency department with heat-related illness are being transported by EMS. And then there is also a link in this dashboard to hospital discharge database, and it gets really very specific information. So one of the pieces, we had a small heat work group yesterday, is talking about if you're looking for grant opportunities, options for kind of how do you see what the impact is on heat on illness and injury in your region. This is available. So I wanted to make sure we demonstrated this just to put this out there, especially as it was, I think, like 117 or something yesterday or today. This is the hottest time of the year. It's really high risk, both for our patients, but then also for our EMS responders. So wanted to make sure that everyone was aware of where this dashboard was and the data that is available there. This, as I said, can be filtered by year. It can also be filtered by county. So this current version is displaying 2025. You can see there that's obviously a partial year data. If you go to 2024 data, that will give you the whole year's worth of data. And that is available. The interesting part that we kind of looked at with some of the other data sets is where some months of heat related data is, which is somewhat surprising. Looking in October of 2024, you see pretty decent amount in October. Kind of unusual. We don't think of heat related illness in that time frame, but you see a decent number in that area. So I wanted to just make sure people were aware of this dashboard, as this is not kind of linked to our normal DQA dashboard as it's ED visits.
Thank you. One question that you touched on, and you may not know the answer, totally fine. You said this is hospital discharge database data. I assume it's ICD-10 code data. And I'm assuming it has to be a discharge diagnosis of heat illness, heat stroke, heat exhaustion, something like that is my assumption. But
I would assume so, but again, I'm guessing. There is about a 20-page document that is linked on there that also has the full discharge database, and that may have some more details that's in there as well. Oh, thank you for clicking on the link. Should
I for information.
Is that?
oh, thank you. Can't read it.
Yes.
It's waste everybody else.
Thank you for putting in the heat safety webpage as well in the chat if anyone is interested. So.
If anyone's interested, the median temperature of October 2024 was significantly above average at 97.9.
So that is fairly accurate, I suppose.
All right. Thank you. Any questions, comments regarding the heat dashboard? Other questions, comments? All right, let's move ahead then. The 2024 EMS dashboard.
So, I apologize. I think we had the slide that I sent you from Watsville yesterday, just before, sorry, before we move on. So one of the things we realized, so this is, as mentioned, was hospital related data. We have been trying to capture EMS related heat data. And that is somewhat challenging because typically EMS is going to put a primary impression. But if someone has altered mental status, altered level of consciousness, cardiac arrest, that might be their primary impression. Unless somewhere else in there, like a secondary impression or complaint, they put heat, we are not going to capture that data. So this is kind of a preliminary run that we have done looking at data. And you can see a little interesting pattern here with some of this data set. The first thing I noticed is why we have any cases in January, February, or December. My guess is that this is likely if someone's using a drop-down field, they maybe are going for hypothermia and clicking hyperthermia is potentially a reason for that. The other thing, when you see these big changes, as Vatsal pointed out, looking at June, especially you see 2023, 2025, pretty similar numbers and a massive spike in June 2024. Now we did look at the temperatures. June 2024 was a really hot month. So you might see some of these swings, but we are kind of trying to figure out why there is a decent discrepancy in some of this data. So that is one of the pieces that we want to kind of talk to this group about. Any thoughts on how to improve kind of some of the heat related data from the pre-hospital side. It's really why we haven't published a heat dashboard from our AZ peers data, because we just felt like it was probably underreporting the number of incidents. So wanted to see from an agency perspective what people's thoughts are. Eve?
Could be
Exertional hyperthermia, yeah, certainly could be for the colder months.
the next slide.
Sure, thank you. This is the number of incidents by county based on population. It makes sense that Maricopa County is going to have a very high incidence. The next slide, which I think gets into, is our data necessarily accurate? This is a rate per 100,000 Arizona residents. So you can see some very high rates along the western border of the state. But again, when we see these massive discrepancies, we start to question the accuracy of the data. Just when we have one county that may have such a massively higher rate of heat-related incident illness, when we know there's many other parts of the state that have the same temperature. So,
yeah, so pretty poor resources. Housing is a contributor over there. Yeah.
So that is something. Thank you. One of the things we realized, Shelley, yesterday, had pulled a Google map with the actual counties on there, since the county names didn't populate to this one, just so we knew all of them. But this is why we kind of haven't at this point published AZ peers data for heat. But there is a lot of tension at the statewide level, nationally, as well as with many cities. So I think a plug for talking to amongst your agency. I know some departments from their city leadership have added heat specific questions to their EPCR, but these are custom fields. If it's a custom field, that's likely not going to make it into the AZ peers data. So great for your city if you're able to collect that data, but not necessarily if we're looking for statewide data.
Well, that is consistent with hospital discharge too, though. They were really high. I think I don't know what the rate per 100,000 is, but it's like 300 or something. That's high.
Good to know. And then this just breaks down from our AZ peers data, kind of the gender, age group, race, and ethnicity. So breakdown with that. So this is our preliminary EMS related data. As I said, we want to make sure that we really have a good accurate picture before we were to publish this. We do feel that this is likely undercounting cases just based on knowing that many times EMS is going to put a primary impression, and many, especially severe heat-related illness, that primary thing may end up being cardiac arrest, altered status.
We talked to BEMSTS at all to ask if they have considered making this an update, like an official update.
NEMSIS actually does have it. We shared that yesterday, has a big heat dashboard. And Anne could probably speak to that. It's again based on the data inputted. So it's the same element that we have. I think the key is
Like a specific field, like adding a new specific field that was
like a specific heat related.
Yeah, to make it not a kind of like we do for trauma and some other things where it's not a custom field. It becomes its own separate thing. So
And do you know if NEMSIS is working on that at all? Any specific heat related questions as kind of part of their total data set as opposed to custom elements?
I'll try to make this a short answer. So anyone can request, including anybody in this committee, can go to a link, and I can give you that. I gotta find it, to request data elements to be added to the next version of NEMSIS. It's something where at our the annual NEMSIS meeting, that's something we generally vote on, what to add and what not to. It usually takes several years for it to get into the data set because of the process. It sounds like a long time, but then when you think about also the opposite of how much change it takes to do this kind of things, you know, and agencies and all the training they have to go through, and vendors, all the development they have to go through. As far as I know, they're not adding anything specific to this, partly because there is a lot of time-sensitive illnesses, as you guys know, that there's not a specific question about. We have some like cardiac arrest or injury, but in general, it is discouraged to add specific data elements for one thing. You know, as a state, we could add a custom element. We need to get all the vendors to add it, and that's kind of complicated on its own. It doesn't mean we can't, but right now, agencies can absolutely document this, not only as a primary impression, because I get sometimes it's not the primary impression, but you can have as many secondary impressions as you want, and it'll be captured there, or it'll be captured in primary symptom or other symptoms, which is following the national case definition for heat-related illnesses. So I don't see it coming out as a separate data element anytime soon.
Thank you. Great information. Any other comments on heat before we move on? All right. Moving on then now to the 2024 EMS dashboard.
I think Vatsala is going to cover this.
Yes. Hello, everyone.
Good morning.
Good morning. Shelley, we can go to the pre-hospital incident. This page is just the introductions, talks about the methodology, and some references are there. I did present this dashboard last time when there was only 2023 data available. This time, because of the modernization of data structure within the ADHS, now we moved to everything, we are moving everything to Snowflake, and all the databases is available kind of at one place. We were able to do the 2024 data early, and instead of waiting till almost end of the year. And so now the plan would be, because EMS data is a real-time data, we are going to plan that as soon as the year ends, we will wait for, a quarter or something and publish the annual report. So what you are seeing over here is 2024 data, and then if we click on the drop-down box for the year, we have from 2020 to 2024. So last 5 years of data is now available. Just because the size of the data is so huge, we plan to keep it at 5 years. So then the next year when I update the data, we will add 2025, but we will remove 2020. It takes otherwise a lot of resources, and the time to load. It's such a huge database. We have the filters available. We can filter the informations by EMS region, by age groups. We have pediatric and geriatric population available. So the entire dashboards, wherever possible, I have given that option. So if we are just looking for the pediatric group, we can filter it down for almost all the tabs, the pediatric group. And then we also have 911 response and interfacility transfer under the response stand. So we can filter it just to see the 911 picture or the interfacility transport. So what we are seeing over here is just a very basic general information about the EMS calls, is like how many total incidents were there. There were like around 1.2 million EMS incidents we recorded in EZP years, which kind of gives us a daily average of 3,414. Total patients involved, we have one or more EMS agency report data on the same patient. So when we look at total patients, it's going to be a little less than the total EMS incidents. And that's what we see that, 1.2, but, the total patients involved are around 1 million. We tried to remove the duplicates as much as possible. That does not mean we might still have a little more duplicates still involved in that 1 million denominator. So little less than that number of patients involved. When we talk about SIM fatality, we had total 8,486 SIM fatality, which gives rise to 0.8% of the EMS calls. What we see other things are the EMS incidents by month. It is pretty much same around all the months. Type of locations is that's like private residence, like 47% of the EMS calls are originated from the private residence, followed by the medical facility, and then 10% from the street and highway. Majority were reported by the ground agencies, 97%, and the 2% by air agencies. We can go on the next page. The next page is about the demographics. This page also, again, as I told you, we have the year filter and the age group, so we can filter it just for the pediatric too. The demographics, it's the standard. We have age, gender, and race and ethnicity, and by county information available. And for the EMS purpose, we do also have the region table available. What we see under the like male and female kind of equal distribution between the using the EMS services. For the county, what we have seen is that mostly the rural counties end up using more EMS services compared to the urban. Though the call volume would be higher in the urban just because the population is very high. But when I take care of the population and use the rates, we see that our rural counties are using it more, especially the highest is La Paz County. And American Indian population tends to use more EMS services compared to white, and I mean American Indian followed by black and then white. And the age, when I see the number of incidents wise, the number of EMS services calls are more as the age. Sorry, someone have a question? Okay, yeah, so the age is that I have the incident and the total number of incidents and the rates, both the graphs are presented. You can go to the disposition. The disposition of table is derived from the EMS primary and secondary impressions. So we took the primary and secondary impressions, the way we collect is in the form of ICD-10 codes. And those ICD-10 codes were then categorized using the HCUP framework. And I have the link available on the website. People can go and look into it. This is the framework provided by Medicare services. I mean, they have it's a very standard framework used by many of the agencies to categorize into broader, meaningful categories. So here we have all those EMS impressions categorized into meaningful categories. What we have the highest number, if I see over here, is that symptoms, signs of abnormal clinic and laboratory findings are not elsewhere classified. That's going to happen with the EMS agencies just because they are not the people who are trained into ICD-10 codes or not the people who are able to diagnose it. So stories are going to be more. But what we see is that 10% of the EMS calls are mental, behavioral, and neurodevelopmental disorders. And then 9% are on disease of the circulatory system. And then we can just look at that way. And once you click on any of the impressions, like say if I look at the mental and behavioral category, it will tell you what the age group is and what was the disposition of the patient. I can go to, for example, disease of the nervous system, and then it will change the pattern of age groups and the disposition for me. So we can select over here in EMS impression.
Bansal?
Yes.
So one of the things I wanted to point out was when you look at the number one kind of primary impression, almost 40%, it says symptoms and abnormal not elsewhere classified. So that's essentially what EMS is putting no primary impression or unknown. And I think that's just kind of an educational piece of recognizing that the vast majority of time, I don't think EMS recognizes the importance of this actual field. So what is your primary impression you think is going on with the patient? Do you think this is respiratory? Do you think it's a STEMI, cardiac arrest? I see many cardiac arrests where the primary impression is unknown or no no complaint, where that could be a pretty easy fix. So I think that's just a little education piece as we look at our patient population, is to say, really, this number, this percent of kind of a no primary impression should be a pretty small one, as opposed to being 40% of our data set. So just a quick data piece I wanted to point out. Thank you.
Yes, thank you. Just because the EMS impressions are so broad over here, we also have next 2 tabs available, which can go into the details of, some of the important ones. So one is the injury, and so we selected all the injury patients. Yes, Anne.
Sorry, I just wanted to segue off of something Gail mentioned about the specific table before we move on. So
Sure.
for agents out there, hopefully, and if not, please contact me. You should be getting a brand new, just started like a month or 2 ago, called a monthly snapshot report. And one of the tables on there is your agency's top 10 impressions. So this is a great place to potentially look and see if you perhaps are transmitting, if not filling out, or transmitting very non-specific impressions to our system.
Perfect. Yeah. So now the injury is that if we identify from the primary impression table, if there is an injury ICD-10 codes, or we also have another variable we collect, is that injury, yes or no, and based on that, then it gets classified into, using the CDC injury framework, into different categories of injury. So our fall is the highest number of EMS call incidents, like 42% of all the injuries were due to falls. And we found the same pattern in our trauma registry also, that the fall is our number 1. And the second one is unspecified. Again, it's an education piece over here. Then the third is struck by, against, and then MVT occupants. In our trauma registry, we do have fall first, and then the MVT occupants. And it's struck by. I don't remember whether it is 3rd, 3rd, or 4th, but it is in top 5. So we see the kind of a similar picture even on the EMS side. Here also, I think you should be able to see, if you select the fall, and then it will give you some of the age groups, injury, intent, and the patient disposition, everything changes. So you can kind of, if we are looking for little bit detailed information, we can just click on one of the injury mechanisms, and then it will give us the demographics of those injury mechanisms. Then after the injury, let's go to the next step, which is time-sensitive illness. We have selected some of the time-sensitive illnesses, and the specific one, like cardiac arrest. If we click on that filter, cardiac arrest, diabetes, drowning, we have STEMI, stroke, are given over here. So we can just see number of cardiac arrest, and then we have the demographics available by age group, by gender, more among more among males than female. Then we do have some county specific information available, the rates and patient disposition. So all that information is but down specific to specific to the illness. So we can choose any of the illness, cardiac arrest, we can choose diabetes, and then look at it, how many total EMS incidents, around 8,400 EMS incidents of diabetes, and then giving a picture of diabetes, by some of the major demographics. The next tab is air transport. This is, I do not have the age population over here, you cannot filter these by pediatric or something, just because some of the numbers are very small then. So what you are seeing, that there were total number of 25,000, around 25,000 air transport, which is daily average of 71. Over the years, the air transport are kind of increasing, but also that makes sense that our population is also increasing. When we look at the county specific, yes, the rural counties are higher compared to urban, and it should be that way. So that looks right. Then it gives that transport rate by by age groups and by the response type. So most of the air transports were 77% are interfacility transports, and 21% were originated from the scene. And the last is our ground agency response time. So here, how I have done is that this page is basically the response time is only for 911 response call incident. So, if it is a 911, then we looked at the response time. And our median response time is basically 7.5 minutes with I've given the quartile 1 to 3 between 5.8 to 10.2 is the range. Same time is around 11.7 million minutes, and again, anywhere ranging from 6 to 17 minutes. And if the patient were transported to the hospital, so if you see the 911, we have 994,000 cases or 911 and 639,000 transported to the hospital. So those who transported to the hospital, what was the transport time? That's how it actually is. So, kind of we can figure it out from here. I have given N at the bottom of each graph. So where the response time available, it says 992,000 to 796. So it's like, okay, that's the time available. And then my numerator is right on the top. It says 911 response call incident. So there were total 994,000. So it's a pretty good response time. I mean, that means we are good in data collection, but that kind of gives us the information that when I look at the same time, I mean, that is a drastic decrease. I mean, look at that. It goes to available only in 800,000. So that means we do need some kind of data quality over here, because now that means we are not getting the same time from every agency. And then again, similarly, when we see the transported to hospital, my denominator is 639,000 cases, while transport time was available on 590,000 cases. So some of the data quality information is also given on this page. And then we have on the bottom, we have county specific ground agencies 911 response time and county specific ground agencies 911 transport time. And when you put a mouse on the cursor on any of the counties, then you should be able to see what was the median, what was quartile 1 and 3. So that's about it.
That's all. I think Matt has a question in the room.
I was wondering, is it possible to see how agencies, the response type that they were responding, lights and sirens, non-emergent response, is that possible? And then my next question would be, is it possible to see, would it be possible to sift out how many patients that lights and sirens were responded to truly required lights and sirens? So maybe the surrogate would be that if they transported lights and sirens, I think that would be I think that'd be interesting.
At the state level?
I think the question is the state level. I don't think we could answer the second one. And part of that would be when you look at kind of the white paper and reduce the lights and sirens use, they do talk about sometimes you need to get on scene faster to kind of triage that patient. But then once you've triaged that patient, while they may have something that's urgent or emergent, does it indicate the need for lights and sirens transport? So a lights and siren response may be indicated, but the transport might not be. So I don't know that those two correlate with one another, but I'll let it also answer the question about the transport response or the response. Yeah. Response.
Sorry, Dr. Bradley, did you tell me anything? I missed that.
The question for you was, can this data pull the response, whether it was code lights and sirens or not, or for the response? Do we have that data?
Yeah, and I would actually better answer that question. We do have that data column available. So yes, based on that, I can do the analysis. But how accurate and what is the quality, that Anne would be able to answer that question.
Hello. So the lights and sirens would be difficult to do because the field that it's collected is called additional response mode descriptors, and it's just a list. It doesn't say how long. So we lights and sirens. It could also say, and then in the same list, no lights and sirens, traffic patterns, not traffic patterns. There's no way to tell how long and what happened when, the duration, any of that. So what we use is as an alternate, and every EPCR has to have this. It's a mandatory element. Is response mode to scene. I think it's e-response 23. And that one is, you have to answer one thing and it's a single pick. It's either emergent, non-emergent, emergent downgraded to non-emergent, or non-emergent upgraded to emergent. And right now we use that as part of our response times report that CON holders have to do. So I'm not going to, the data quality should be really good. I mean, unless you're answering the wrong thing, but the completeness should be excellent on that particular field.
So if we can use that particular field, then yes, definitely I can divide the response time by those categories and we can look at the transport and response both.
So it sounds like we have data types of response, but I think that might be agency specific as what they view as emergent. Does it equate to always licensed sirens response or not? I don't know that those necessarily would equate. So depending on time of day, traffic, etc., you might have not have lights and sirens response, even though it was emergent. So I don't know how accurate that would be to the reflection.
Thanks, Matt. Other questions, comments, or Vatsal, do you have more to add?
No, I am good.
Okay.
Yeah.
Great. Thank you. Thank you for the presentation and great information. Unless there are other comments on the EMS dashboard for 2024, we will move on. All right. Item 7 on the agenda is call for agenda items for the next meeting. If you do have an agenda item, please send that to Shelley. Her email address is on the agenda for today's meeting. Next, we have our call to the public. Public comments. All right. Next up, upcoming events. You can see the quite lengthy list of events. We have some things in July, August, September, October, November, and December. So something every month for those of you anxious to learn or have fun. You can see a list of all the events at the Bureau's website. You can also see the link to that website on the agenda. With that, our next meeting is November 20th. I hope to see you all then. Otherwise, we will call this meeting adjourned.
Thank you, everybody.
Thank you.